Good morning, everybody. The task assigned to me for today is to discuss about the management of chronic stable angina in 2020. I would like to congratulate the API Malwa branch for having organized this virtual meeting even during these difficult times. Well, the term as it is used by the American guidelines, initially in 2002 they said chronic stable angina, and subsequently they changed it to stable ischemic heart disease in 2012. The Europeans used the term in their guidelines as stable coronary artery disease in 2013, and now this new term which I am actually discussing is chronic coronary syndromes, which was proposed last year by the European guidelines and has become pretty popular because it encompasses almost 6 kind of clinical scenarios. One, of course, is that of the stable angina patients that come to us, common garden routine patients who walk into our clinics. But it also includes patients who are asymptomatic in whom coronary artery disease has been diagnosed, those with microvascular angina, those who present first time with heart failure but have stable coronary artery disease, and those who have recovered from an acute coronary syndrome of a period of less than 1 year or even subsequently. So it just tells us that chronic stable angina is now actually a part of the chronic coronary syndromes because there are a lot of overlapping things that we can do which are same in these patients. Two important terminologies for stable chronic coronary syndromes, because we know most of these are based on obstructive coronary artery disease, but just as we have MINOCA in patients with acute coronary syndrome, myocardial infarction, no obstructive coronary artery disease. Similarly, we have INOCA, ischemia, no obstructive coronary artery disease. So in chronic coronary syndromes, you can have an obstructive coronary disease, and the functional abnormality in chronic coronary syndromes that you will see can be in the form of focal epicardial coronary artery disease, which is amenable to PCIs. It could be in the form of diffuse epicardial disease, which are patients which are very difficult to treat because they have no targets for bypass, and PCIs are at times their syntax scores are very high. Some of these people could be having vasospasm, myocardial bridging, which is an innocuous thing, but you do diagnose on coronary angiograms in some of these patients. And as I said earlier, microvascular dysfunction, endothelial impairment, but no obstructive coronary disease can be there. The value of good history taking in these patients is enormous because we know typical angina is based on two things. Heaviness in the middle of the chest, in fact it's a constricting sensation, and often when you are in your clinics and you ask your patient where is the pain, they will always say that doctor, I have no pain. Some will say heaviness, some will say constriction, some will say breathing difficulty from the jaws down to the epigastrium. It is precipitated with exertion and it's relieved by rest. Now a typical angina in men is of course more often suggestive of coronary artery disease than atypical angina or non-angina. Typical angina is when both these things are there, retrosternal location and precipitation with exertion. Atypical angina when one of the two is there, and pain is called as non-anginal when neither it is retrosternal nor is it precipitated with exertion. We know as age progresses, the probability of coronary artery disease increases, and the same symptom in men connotates more often obstructive coronary disease than in women. In fact, whenever a patient of stable coronary artery disease walks into your clinic, you have 3 questions in your mind. The first thing that you want to decide is my patient having coronary artery disease, or is this pain due to a non-coronary disease? Once you have ascertained that your patient is having obstructive coronary disease, the second thing that comes to your mind is my patient a high-risk CAD patient or a low-risk CAD patient? And the third question that comes to your mind is, should I send this patient for a coronary angiogram for intervention, or should I treat this patient medically? And it is these 3 questions which we will be answering in this next part of our lecture, so that one answers as to what way we have to deal with our patients who walk into our clinics with chronic stable angina. We all know exercise ECG testing has been the standard method which we have been using for risk stratification of these patients. Exercise capacity has to be looked at. Someone who walks for more than 7 metabolic equivalents does not have a severe disease. Good rise in blood pressure is a positive sign. And the exercise-induced ischemic change along with pain, these 4 things actually are components of the Duke treadmill score, which risk stratifies our patients as to high risk. If patient has downsloping ST depression early in exercise, which persists for a long time, obviously patient is likely to have a multivessel coronary artery disease. But our focus is now shifting from what we used to initially think as a pre-test probability, where we used to take age, sex, symptoms, as I said, typical, atypical and non-angina chest pain. We also now look at the risk factor profile. Someone who has diabetes, dyslipidemia, positive family history, smoker is obviously more likely to have coronary artery disease with the same symptoms. LV functions are very important, and echocardiogram should be a part of your initial evaluation, just as an exercise ECG I said. The CT coronary calcium scoring came. It is useful, but clinically not so often used. And so I want to emphasize here that it's the clinical likelihood of coronary artery disease, that kind of an approach which you have in your mind when you are looking at these patients. So just to recollect again, we assess their symptoms, look at their associated other risk factors, do an echo, do a stress test, only if we feel that the probability of coronary disease is high. If the probability of coronary artery disease is low, then in that situation actually a CT coronary angio is useful. So CT coronary angiogram done by an expert in a situation where interpretation can be obtained significantly in now a part of our armamentarium, because the Scott Hart trial showed us that CT coronary angio in chronic coronary syndromes is important in those in whom obstructive CAD cannot be ruled out. The NICE guidelines in 2016 in fact discarded the Bayesian pretest risk assessment, and they advocated a CT coronary angio for typical or atypical angina patients. And you all know NICE guidelines are, the British guidelines are based actually on cost effectiveness, unlike the US ACC guidelines, which are more on evidence-based randomized trials. But the NICE guidelines do take into consideration the cost considerations. And now the ischemia trial has actually shown us that do a CT coronary angio in a patient, rule out a left main coronary artery disease, and then you can treat most of your patients medically also. If we look at the diagnostic accuracy of non-invasive tests, as has been shown, the sensitivity and specificity of exercise ECG is much lower than that of stress echo or SPECT, and in fact stress echo done in good hands has one of the highest sensitivity and specificity. But what I want to emphasize is, if your patient has a low probability of coronary disease and you want to rule out coronary artery disease, a CT coronary angio has a sensitivity of 98% and a negative predictive value of 99%. The specificity is less, so to rule out in patients with less probability of coronary artery disease, do a CT coronary angio, rule out coronary artery disease. The CT coronary angio, the non-invasive tests actually how they can help you is by risk stratification in patients into high risk ischemia. So Duke score in exercise ECG, more than 10% of the myocardium if you have on a stress SPECT perfusion imaging, stress echo showing more than 3 segments out of the 16 segments of the left ventricle if they are showing ischemic changes with dobutamine stress echo. Cardiac MR we are not using so much in our country, but is being used outside. And once you have done a coronary angiogram, a functional invasive testing with the FFR, fractional flow reserve, is very important because it tells you the significance of a lesion, whether it is hemodynamically. What to your eye might look significant at times might hemodynamically not be significant, and can be the other way around also. Once you've diagnosed your patient as coronary disease, you have a reasonable amount of assessment by one of these non-invasive tests that I said that my patient belongs to a high risk or a low risk category, then obviously the first things first, you have to do a risk factor modification, because we know the disease has occurred because of these risk factors. So their weight management, smoking cessation, their psychological assessment, good blood pressure control, diabetes management, all cannot be overemphasized, and good amount of heed needs to be applied to these various aspects. Diet is a very important factor, and we know moderate consumption of nuts is very good. Liquid vegetable oils should replace the saturated fats in desi ghee and butter, and we should not take trans fats, salt and sweetening sugars. So all these white things, desi ghee, sugar and the polished rice, maida, all these things are harmful, and there is a lot of data now. People who consume more of carbohydrates, more than 60% of your total caloric intake in Indians is higher than other communities, and more carbohydrate consumption is a factor which increases the risk of non-communicable diseases. The treatment of angina, the angina pharmacotherapy actually essentially revolves around the anti-anginal drugs, that is beta blockers and calcium channel blockers. So these are the first line agents which are used for treatment of symptoms of these patients with which they have come. You will use beta blockers or calcium channel blockers first, initially one of these, and then combine them. But there are two set of agents which improve their longevity of life in these patients. That is aspirin as an antiplatelet agent, statins as hypolipidemic agents, and ACE inhibitors or receptor blockers. These three agents are secondary prevention measures. So something you will do for relief of symptoms, and the rest you will do for improving their longevity of life. And in fact, these newer anti-anginal drugs like nicorandil, like long-acting nitrates, ivabradine, ranolazine, they are only to be added once you have used the first-line anti-anginal drugs for symptom relief, and if your patient continues to have symptoms. So aspirin, as I said, in chronic coronary syndrome patients with normal sinus rhythm, use 75 to 100 milligram of aspirin in all of them. Only who does not tolerate aspirin, you can use clopidogrel 75 milligram once a day. Once your patient has had a PCI, the approach is different from PCI when it is done for acute coronary syndromes. Here the DAPT, the dual antiplatelet therapy, is given for 6 months. And if your patient is very high risk, the DAPT is to be given for 3 months only, especially with the newer stents which has a smaller strut thickness and which get endothelized faster than the previous bigger strut thickness, heavier stents that we were using earlier. So 6 months here, whereas in post ACS PCI we give it for at least a period of year. So see whether your patient had a PCI for a chronic coronary syndrome or whether it was done for an acute coronary syndrome. Well, atrial fibrillation is present in about 15% of patients with chronic coronary syndromes, and we now know that the NOACs, the newer oral anticoagulants, are to be preferred over the vitamin K antagonists. Use it when the Chad-West score is more than 2 in males and more than 3 in women. But the newer drugs, including dabigatran and epixamide, and these drugs can be preferred over the vitamin K antagonists. And luckily, all the 3 newer oral anticoagulants are now available in our country. In post-MI patients, along with the newer oral anticoagulants, you can combine aspirin, but it's a class 2B indication because vitamin K antagonists in AF and CCS alone would be sufficient. Now, if you had a patient who has atrial fibrillation, chronic coronary syndrome, post-PCI, in these patients, triple therapy, the dual antiplatelet drugs with the NOAC or the vitamin K antagonist, has actually very high bleeding risk. So you use 2 drugs, and after a week of the PCI, you withdraw aspirin and then continue these patients on a NOAC plus clopidogrel for a period of 6 months, after which time the clopidogrel will be withdrawn and you will continue for the atrial fibrillation in a chronic coronary syndrome with one of the newer oral anticoagulant drug. Mind you, ticagrelor or prasugrel, the P2Y12 antagonists which are used in acute coronary syndromes and are preferred over clopidogrel, have no role when PCI is done in chronic coronary syndrome patients, especially when very complex procedures with multiple stents are not done. When patients have multiple bifurcation stenting, left main stenting, of course you can use these agents, but in routine patients in these situations, clopidogrel is preferred over these newer antiplatelet agents. So besides these antiplatelet drugs, the second class of drugs that we use is statins, and they are the agents which make the biggest difference in terms of mortality and prolongation of longevity of life of these patients. And mind you, we have to use high intensity statins. Often we combine with ezetimibe, and the newer PCSK9 inhibitors are expensive, but they are very effective, and patients where you are not able to achieve the LDL levels of 40 to 50 on these two agents, then you will obviously, if the patient can afford, you will use these injectable PCSK9 inhibitors, which have been proven in multiple trials to be of benefit in patients of coronary artery disease. Patients should all receive either an ACE inhibitor preferably, or if they develop cough with ACE inhibitor, then an angiotensin receptor blocker, because they also benefit in terms of secondary preventive agents. Coming back to the drug therapy for symptom relief, as I said initially, beta blockers or calcium channel blockers are the preferred agents, and as a second step you can combine a beta blocker with the dihydropyridine calcium channel blocker. But if your patient has heart rates, has bradycardia as such, then you can use a dihydropyridine as the first agent. Patients with heart failure with CCB, chronic coronary CCS, obviously beta blockers are useful. ACE inhibitors, receptor blockers are again of enormous benefit in these patients. And as I said, these newer three anti-anginal agents, ivabradine, nicorandil, ranolazine, and of course the fourth one, the metabolic trimetazidine, all four have to be used only for symptom relief, and if patient continues to have angina after you have given beta blocker and on CCB, or more often both in combination, and a long-acting nitrate. So use them judiciously and do not use them as first-line agents, because there is no mortality benefit that has been shown, and it will only increase the cost to your patients. In fact, use high-intensity statins. Never miss out on that, because that's what is going to make the biggest difference in terms of medical therapy. So as I said, we use these agents sparingly. Besides this, PPIs should be used, proton pump inhibitors, whenever patient is on aspirin or dual antiplatelet. We know any individual more than 60 years of age, we are living in the COVID era, we know vaccination in elderly has a specific place. So H influenza, the flu vaccine and the pneumococcal vaccine, the flu vaccine every yearly and the pneumococcal vaccine every 5 yearly, and hopefully we'll have shortly the COVID-19 vaccine also, which we will also incorporate in the adult vaccination program that we have been having. We all know SGLT2 inhibitors in the latest ESC guidelines. Now data has been presented for heart failures also. Any patient with coronary artery disease with diabetes should be put on SGLT2 inhibitors, because there are enormous significant mortality benefits in terms of cardiovascular events, in terms of renal events that you see in these patients. So they should not be deprived of these agents. The next question in the next 5-7 minutes that I'm going to answer is, what comes to your mind? Should I continue to treat my patient medically, or do I take him to the cath lab for an angiogram? We know these patients can be very diverse. Patients of left main coronary artery disease, triple vessel disease are at a much higher risk than patients of single vessel disease. But we also know that patients of ACS and STEMI are always, whatever is their coronary anatomy, at a much higher risk than chronic coronary syndromes, because of the very nature of the disease, because there a plaque rupture has happened, but in this case the plaques are stable. So here lies the actually wisdom of a clinician in terms of looking at which patients should go for an angiogram, which patients should get an intervention. And the Courage trial, a large trial published in 2007, actually addressed this question. And what it found was that actually there was no difference between optimal medical therapy and PCI at the end of 7 years. In fact, in 2015, they published the 15-year data in the New England Journal of Medicine, and they showed that mortality in the PCI group was 25%, whereas the mortality in the OMT group was 24%. So no difference in the Courage trial. We know patients who were very highly symptomatic, 1/3 of them had to be shifted to the PCI group within the first year. But those whose symptoms had disappeared, they fared as well as the PCI subgroup did. We felt that bypass is more beneficial, especially in diabetics. So we did the BARI 2D trial, which was published in 2009. And this trial again showed that optimal medical therapy is actually, the 5-year death rate was similar, 13% and 13.5% in the two groups. And it kind of actually, we developed respect for the optimal medical therapy, and we realized that these patients do as good if actually we are using drugs in optimal dosages, and patients' compliance, lifestyle modification, all these things make a big difference in terms of keeping them stable form and giving them many more years. The FAME2 study looked at fractional flow reserve value in patients with multivessel disease, and it did show that whenever PCI is done based on functional assessment, it is always better than PCI which is not done based on FFRs. And so the ESC 2019 algorithm actually suggested to us that patients with more than 90% disease, FFRs of less than 0.8 or ejection fractions of less than 35%, one should consider revascularization, because at this time we all believed that if there is a significant stenosis and if there is patient is symptomatic and FFRs are significant, then we need to take them to the lab. The ORBITA trial actually is a very interesting trial. It is a sham control trial, and then editorial with this actually said the last nail in the coffin for PCI in stable angina. What they did was they took 230 patients and they put these patients randomized into PCI versus medical therapy, and what they found was that the symptom relief was similar whether you put these patients for a PCI. In fact, they did stress tests. Mind you, the ORBITA trial was based on FFR. So this particular trial showed that there was no significant symptom relief. But the ischemia trial, which was published in this year, actually people have been looking at this particular trial. It's the largest trial ever to have been done by the NIH. It's a $100 million trial, one of the most expensive trial done on mankind. And we were part of this trial, and we were fortunate to enroll one of the largest number of patients from any single center. The total, they had 5,000 patients, mean age was 64 years. These patients were having severe ischemia. They had strongly positive stress tests, less than stage 2 TMT positive, and 79% of them had multivessel disease, 47% had proximal LAD, 87% had LAD disease. So this was a high risk subset of angiographically, high risk subset of patients. Optimal medical therapy was emphasized very significantly, and we at DMC achieved very good blood pressure control because of our emphasis on this particular aspect. And in fact, we were awarded for this particular one of the best blood pressure control having been achieved at our center all across the world. But let's come back to the results. The results showed that at a mean follow-up of 5 years, there was no significant difference in the primary outcome of CV death, MI, hospitalization, or heart failure. All cause deaths were similar, but angina relief was much better in the subset of patients who were subjected to PCI or CABG than medical therapy. And so in fact, the Rashomon effect had to happen. Different people, the interventionists interpreted it in a way that there is better symptom relief. The non-interventionists feel that the mortality benefit is not there, but as clinicians, our ultimate aim is to give the maximum benefit to our patients in a cost-effective manner, and so the Goldilocks phenomenon has to be used. It's never too much. The optimal medical therapy is never going to be too much, and so the trial actually concluded by saying that there was no reduced risk at a mean of 3.3 years although there was significant durable improvement in angina control and quality of life. I will end here with this editorial which summarizes our approach to patients of chronic coronary syndrome. In fact, this has been written by a registrar who says cardiology is steadily moving away from a gung-ho invasive approach towards an era of imaging functional testing to guide our revascularization strategies. So our ultimate aim is to make our patients survive longer with better relief of symptoms, and we have to use all these aspects, our clinical judgment, in a judicious manner. Thank you. Can I